Dear doctor, good afternoon. Thank you very much for joining us. Welcome to DigiNeuro, a digital initiative by Health and You Therapeutics, a joint venture with New Link Company Limited, Japan. Health and You has a vision to fulfill unmet medical needs by launching innovative, first time in India products. Products like Anurite, Amitriptyline plus Mecobalamin combination for migraine and for neuropathy. Products like Neurite injection, which we import from Japan to give you 100% mecobalamin, to give you highest quality. Products like Amnurite beta, amitriptyline plus propranolol combination for the first time in India, when one drug is not enough for migraine. Amnurite beta 520 ER, Amnurite beta 1040 ER. We were the first one to give you pharmacological combination for neuropathic pain of two neuroanalyses, amitriptyline and pregabalin. Pregabalin is given in a sustained release form to match pharmacokinetic profile of amitriptyline. Therefore, we call it is pharmacological to offer your patients a 24 hours pain relief. We are the first one to launch a new strength of clobazam, add clobaz 2.5 milligram, 5 milligram and 10 milligram to offer you flexibility and control in epilepsy and in febrile seizures. Very soon, we will be launching for the first time a vitamin therapy for migraine and many more with your suggestion and with your support. I have great pleasure in announcing the part 2 of our headache webinar with the headache specialist of the country, Dr. Ajit Verma. This part 2 of the webinar will be coordinated by Dr. Manjusha Patankar. She is MD Pharmacology from the well-known KEM Hospital, Mumbai. Over to you, Dr. Manjusha. Please carry on.
Yeah. Good afternoon, everybody. We take great pleasure in hosting this webinar on headache, the management of migraine. Today we have with us the eminent and renowned neurologist, Dr. Ajit Verma. He has trained in neurology from NIMHANS. He is a senior consultant neurologist at Bansal Hospital. Dr. Verma has trained at the Institute of Neurology, National Hospital for Neurology and Neurosurgery at Queen Square, London, and Ludwig Maximilian University at Munich in Germany. His areas of special interest include headache, dizziness, and post-stroke rehabilitation. He has several papers to his credit in both national and international journals. We welcome Dr. Verma.
Yeah. Thank you. Thank you, Dr. Manjusha and Mr. Nayak. And welcome everybody. And good afternoon to everybody. I hope everybody is safe. So today we talk about headache. Could you hear me, please? Hello? No.
Yes, doctor, we can hear you.
Yeah. But you...
Doctor, we can hear you.
But the video, I can't see the video here.
Yeah, you can go to the slide share.
Yeah. Yeah. Yes. Yeah. Slide share. Yeah, sorry. Yeah. And now we go to...
Yes, we can see your slide.
Okay.
Go to the full screen of the slide.
Yeah.
Yes.
So we begin today the management of migraine attacks. Now, many patients of migraine may not take prophylactic treatment. Suppose they are having 2 attacks in a month, they may not take prophylactic treatment. But all patients of migraine need management of migraine attacks, even if they get 1 attack. Now, today our learning points would be, of course, we have discussed how to diagnose migraine, and the closed mimics are hemicrania continua, medication overuse headache, and we discussed last time SNOOP4, the mnemonic for secondary headaches. Then we would discuss about principles of the acute attack of migraine treatment, and one of the key features is an early treatment of migraine attack. The third important point we would talk is classify or stratify migraine attacks. Then we have to select the right medication depending on the type of migraine attack, which is really challenging. And then we would discuss about what is rescue medication if all treatment fails, and then some important carry home messages. So migraine attacks have very characteristic features. One of them is that 80% of the migraine attacks are severe. And there are usually 1 to 2 severe attacks in a week. The duration is quite long, more than 24 hours, and 75% of the female patients. 50% migraine attacks are early in the morning, between 4 to 9 a.m. So by the time patient wakes up in the morning, there's already a full-blown attack of migraine. And besides headache, nausea in particular and vomiting are considered one of the most unpleasant sensation associated problems in migraine. Now, in the principles of acute therapy, we have following points to be discussed. One is what the patient expects from us from the treatment of migraine, which is very important. The second is the early treatment, use of anti-emetics, which is a baseline. Then we have to classify the migraine attacks. We have to match the treatment, the formulation, the type of drug we have to use, and the combination. Now, this is very important, and it's not that you write a prescription and drug would be effective. No. One drug may not work in the acute attacks, and we may have to change. So normally we give a treatment of acute attack for 2 attacks or 3 attacks, and then we change. And of course, there are rescue medications. Now, what are the patient's expectations of acute attack of migraine treatment? One is pain-free by 2 hours. Patient expects themselves to be pain-free by 2 hours, and it should be a sustained painful period for the rest of the time. Drug should be consistently working. There should not be any headache recurrence, no adverse effects of the drug, and not only headache, nausea and vomiting should also be relieved, and of course it should be a affordable treatment. Now, one of the principles of acute attack of migraine treatment is an early treatment. Now, early has 2 connotations. One is that in the time phase, within 2 hours, we should treat migraine. Within 1 hour of the onset of migraine is still better. And second is that we should treat while it's mild. When the headache becomes severe, then the drugs may not work. Why we should treat early? Because in migraine, there is gastroparesis as the migraine progresses. If there's nausea and vomiting, patient may not be able to absorb the drug and may even vomit out. As the migraine progresses, there is cutaneous allodynia. That is, the skin becomes very tender, patient cannot lie down, cannot comb hair. If you are late in taking the medication, then if you take early, then there's no recurrence, it's effective. So one tablet may work for 24 hours time or so. And of course, the response is better and the low dose is effective. So if I summarize the early treatment of migraine, it is safe, you give low dose, it's effective, it's economical, and last but not the least, it prevents chronification of the headache. So low dose is the early treatment is a very basic principle of migraine attack treatment. Now, this is the slide which shows that in the scale of severity and time, if you give the medication somewhere here, it is most effective, the best time to give medication early, when the patient is within 1 hour of the attack of migraine and the headache has just started. If you give somewhere here, some 2-3 hours later, when the headache has already become moderate or severe, then the treatment, the patient may not have response. Now, why? There are some barriers in the early treatment of acute attacks of migraine. And one of the barriers is we doctors have to educate our patient that how early treatment is effective and economical and safe. The second problem is how to recognize that this attack is a migraine attack. And we discussed last time, this is the time where we should know to distinguish from tension type headache. Another interesting feature of migraine is that migraine may not begin with headache. It begins with prodrome, and we have to educate our patient to recognize prodrome. Patients with frequent attacks may limit medication, and therefore they may avoid taking medication. Some patients believe that allopathy is harmful, so again they avoid medications. But if we avoid medication, repeated attacks lead to chronification of headache. Migraine, which was episodic, now becomes a chronic migraine. Now, this is very interesting that in spite of educating the patients, 50% of the patients, 50% of the patients still delayed the initial treatment. They wanted to check whether it's really a migraine attack. So recognizing a migraine attack early in the attack phase is a very important aspect of treatment of migraine attack and is a very important barrier if we don't recognize that. How do we recognize a migraine attack in the beginning? The patient doctor should know the prodrome of migraine, how the migraine begins. They should know the typical attack of migraine, which is usually nausea, vomiting, phonophobia, photophobia. It's recurrent, it's triggered. Patient knows that it's time of her menses and she's going to get headache, which is usually migraine. It's pulsatile. Now, this is very important to know that 80% of the migraine attacks are severe. So there's no point waiting for attack, waiting for patient to see whether the attacks become severe. Is going to become severe in 80% of the patients. And some patient also experience that when they take the medication early, there's a good response. And if you delay, there's no response. Now, in identifying migraine attacks, a migraine diary can be very helpful. We'll talk about it a little later. So what are the migraine premonitory symptoms? It may begin with neck stiffness, with irritability, mood changes, dislike for light, not full-blown photophobia, but dislike for light, yawning, thirst, and other symptoms. Now, it's important to recognize to ensure an effective treatment that these are the symptoms of beginning of migraine, neck stiffness. Sometimes the patient gets neck stiffness and they think it's because of the wrong posture, because of the eye strain, because of prolonged sitting, and they may not recognize it is part of the migraine premonitory symptom. Some patients even misunderstand neck stiffness as a trigger for migraine, which is part of migraine actually. Migraine diary can be helpful to recognize these migraine premonitory symptoms. Now, one of the important barriers is distinguishing migraine from tension type headache. One of the reasons is that the initial part of migraine attack may be mild, which may look like tension type headache. Milder attacks of migraine may appear tension type headaches. That means the whole attack is there, but it's mild, but that will happen only in 20% patients. If you study, there's a study of 100 patients of episodic headache, 90% of them landed with migraine features. So if any patient has recurrent episodic headache, it's usually migraine. There's no point delaying the treatment. Again, a migraine diary can help. Now, besides an early treatment, the second important drug which we give in migraine, which is a baseline drug, is an anti-emetics. Because in migraine, there's gastroparesis, and that would delay absorption of oral medication. And these are the 4 drugs. First 3 drugs are also analgesic. They also help in migraine management. And the dose 10 milligram of domperidone is very safe. Similarly, prochlorperazine 5 milligram is very safe. There won't be any extrapyramidal syndromes because of these 2 drugs, but they are all effective not only in themselves relieving migraine, but also in helping anti-migraine drugs to be more effective. Ondansetron is not an anti-migraine drug, it's basically antiemetic. But if there's a lot of nausea, which some patients of migraine can have, then this would be very helpful. This is more dissolving preparation helpful to bring down nausea and to help the patient to take migraine drugs. So antiemetics are a very important part of management of migraine. So much so that we have a lot of migraine drugs in combination with domperidone today available, which is a very synergistic, scientific, effective combination. Now, it's interesting to note that some of the drugs can exacerbate migraine. And one of the important drugs are oral pills, contraceptive pills. And therefore, it's worth inquiring and removing these pills because that may sometimes affect dramatic reduction in the migraine frequency and severity. Both can be reduced. Now we come to the migraine attacks. Now, these are the two important situations. One is the migraine attacks, which we are going to talk about now. But there are special situations like status migrainous, menstrual migraine, very difficult to treat, and then like during pregnancy and breastfeeding. So today we would focus on migraine attacks. We can take some of the questions related to this, or maybe another talk will talk about it. One of the important steps in migraine management is to stratify migraine attacks. What is a stratify means? Initially, we used to stratify into 3 categories: mild, moderate, and severe. But now we know there are many other types of migraine attacks other than a regular attack, which I would talk about shortly. Attacks with distressing nausea, migraine attacks which rapidly peak, that is within 1 hour they reach peak, where an oral medication may not work. Early morning attacks, and sometimes patients have attacks lasting for 24 hours to 48 hours time. Last but not the least, it's very interesting, a patient of migraine may have 2 to 3 types of attacks, and therefore he may need different types of medications to manage these attacks. Let's first understand what is a regular migraine attack, which is seen in majority of our patients. That means of the 100 attacks, 80% will have regular migraine attacks. This usually peaks over 2 to 3 hours time. So patient has time to take the medication. Lasts for the whole day. Usually by evening it subsides. It's moderate to severe intensity, associated with nausea, vomiting, photophobia. And for this typical migraine attack, this is my drug of choice in bold, a domperidone 10 milligram with naproxen sodium. I would first try to use 250 milligram, and if there's no response, then 500 milligram. But the key is not 250. Key is early treatment, and 250 may be effective. If this combination does not work in my patient, despite taking early, then I have Rizatriptan, which I can use 5 milligram to begin with, later on 10 milligram. Always try to use low dose and emphasize more on early treatment than using directly 10 milligram. And if even this does not work, maybe a combination, which is a very effective combination. This is about regular migraine attacks. Now, normally there are 3 important categories of migraine. We have discussed about regular attacks, but 2 more are. One is rapidly peaking migraine, and second is severe nausea, and third is early migraine attacks. Now, these 3 categories would need a nasal spray because that is the fastest acting today available in our country. We don't have subcutaneous somatropin, which was available a couple of years ago. So this is the drug of choice for a rapidly peaking migraine, migraine with lot of nausea, and early migraine. If zolmitriptan is not effective, maybe we can try mouth dissolving wafers available of rizatriptan, but zolmitriptan is a drug of choice. For prolonged migraine attacks, we can use a combination of somatropin with naproxen. This is very long acting. Or we can even use a combination with rizatriptan with naproxen for attacks lasting for more than 12 hours or 24 hours time. Now, a few words about NSAIDs. They are very effective treatment for migraine, even when migraine has progressed. They're helpful in wake-up migraine. Early in the morning, patient can take, but usually patient are empty stomach with some biscuits they can take early in the morning. NSAIDs are synergistic with triptans because the pathogenesis of migraine, there are two things: vascular inflammation. NSAIDs take care of the inflammatory part of migraine. It is interesting to note that triptans may not work in 40% of our patients, and they may respond to NSAIDs, which is cheap and effective and easily available, not habit forming also. And last but not the least, NSAIDs are effective in menstrual migraine also, which is a difficult migraine to treat. None of these adverse effects are seen in a young migraine patient, 15-20 years. And if it does not exceed more than 8 tablets in a month, none of these side effects are seen. It's a very safe drug. And of course, this is my adequate dose. This is my adequate dose, but sometimes a patient may respond to 1000 milligram. But if the patient takes early in the migraine attack, I have never gone beyond 500 of naproxen sodium. It's fast absorbing and long acting drug. So it's a very effective drug for migraine, along with baseline domperidone and early treatment. By the time patients come to me, I'm usually a tertiary referral, so I don't get patients responding to paracetamol. But if I get a virgin or a new patient, young boy of 15 years, student, never taken any treatment, then I would usually write him paracetamol, plus to have a regular lifestyle and avoid triggers. Now, a few words about triptans. Now, it's very interesting that formulation decides effectiveness. Zolmitriptan may not be orally very effective, but its nasal spray is very effective for early migraine. Triptans do not work in all the attacks. So if the patient do not respond to 2 trials of triptan, that means that triptan is not effective. We may have to work through other triptans. Overall, they are well tolerated. Very rare problem of triptans with SSRIs, of having a serotonin syndrome. It's very rare. One should never exceed triptans more than 10 in a month to avoid a medication over a headache. Triptans themselves can produce headache then. There's a word known as triptan sensation, which is characterized by flushing, heaviness, warmth, heaviness in the chest. But usually patients fear that probably drug is producing some cardiac side effects, but usually they are none. It's just a sensation. Again, in a young migraine patient, there's no chance of having a cerebrovascular accident or ischemic heart disease or perivascular disease, uncontrolled hypertension. So in a young 25, 30 years migraine patient, we can easily use these drugs. But of course, they are expensive. And we should never combine triptans with ergotamines in the same day. We should not combine them. That means if a patient, you have given triptan to a patient, then you should not give ergotriptan on the same day. The 3 bold triptans which I am familiar with, I use them frequently. One is sumatriptan. I use usually a combination with naproxen sodium. Zolmitriptan, I use nasal spray for morning migraine attacks. And by the way, this is a very good drug for cluster headache also, zolmitriptan nasal spray. Maybe we'll discuss cluster headache maybe after a couple of other talks. And rizatriptan is also a very good molecule. But when you are giving prophylactic propranolol, then you have to be careful to give 50% dose of rizatriptan. That means 5 milligram and 10, maximum is 10 milligram then. So we have migraine with distressing nausea. Zolmitriptan is drug of choice. And remember that nausea is very distressing to the patient after headache. And even sips of liquid can worsen nausea. And therefore, we have now wafers for distressing nausea treatment. And if patient is not able to tolerate zolmitriptan, or if there is no response to zolmitriptan nasal spray. If you don't treat nausea, there's increased chance of patient going into chronic migraine. So nausea is very much part of migraine attack and should be managed. Now this shows what is a rapid peak attack. Migraine rapidly rises to the peak. This is a regular migraine which takes 2-3 hours time, But here probably it's 1 hour time, it is touching its severity. And therefore here again, a nasal spray is fast acting, effective than an oral medication. Third type of is the morning attacks we have discussed. 50% migraine attacks occur in the morning. And by the time they are already progressed during sleep to the severe attack, and they may have distressing nausea, vomiting. Already it's a fully evolved migraine, and there's no other way out but a nasal administration of zolmitriptan. Remember, morning attacks are difficult to treat, and then if they begin with headache, then the whole day is gone in headache and becomes very difficult. So probably we ask our patient to keep nasal spray bedside so that early in the morning, if they get up with headache, they wake up with headache. It's also known as wake up migraine attacks. We give them zolmitriptan. Now, another category of migraine attacks, many of the physicians might be amazed that there can be so many variety of migraine attacks, and they are, and they need different types of treatment. So we have a concept known as a toolbox of migraine. We'll discuss about it. Now, what are prolonged attacks? They last for 24 hours, 48 hours, maybe longer. There's a high risk of recurrence. That means if you give a medicine, the headache subsides, but after a few hours, it recurs again. But here again, you see, early treatment is very helpful when the pain is mild, and patient may have a pain-free day. Not only patient will have pain-free period, but attack progression can be arrested and may not have recurrence also. So early treatment is one of the key aspects of treatment of migraine. Normally, domperidone, as I told, anti-emetics is the baseline treatment of migraine because there's gastroparesis. Early treatment is essential for migraine. Then I would like to use in a patient with prolonged attack naproxen sodium 500. And if this does not work normally, then I would add somatriptan 85 milligram. And this is a combination tablet available in the market, and it's very effective. If this does not work, then you can also try rizatriptan along with naproxen sodium. But the key is that it should be given early in the attack. As I told, naproxen sodium is rapidly absorbed and it's a very long half-life. So probably sometimes it may work all alone also if you give early. So this is how we manage a prolonged attack of migraine. Now, what is headache recurrence or migraine recurrence? Headache recurrence means reemergence of moderate to severe headache after an initial headache response. And again here, that means you give the medication here, the headache subsides, but it recurs again. There's an initial response and then it recurs. Of course, our early treatment and domperidone baseline is a first line treatment. And if the headache does not respond, then let me tell you what is my algorithm. Now, usually I try naproxen sodium 500 milligram, which is my first drug of choice. It's cheap and effective and safe, but with no relief. If recurrence is there, then I can repeat the same dose. And if there's relief, then I will ask my patient to take naproxen sodium 1000 milligram next time. But it has never happened to me because majority of my patients take early naproxen sodium and they respond. Now, if they do not respond to even 1000 milligram of naproxen sodium, then my next choice would be, I would use here a combination of naproxen sodium and somatriptan 25 milligram and would expect that there's no recurrence. But if there's a recurrence, even with this combination, then I may try rizatriptan. Maybe 10 milligram is the maximum dose to begin with 5 or directly 10 milligram. And if there is no relief, then probably then I can ask my patient to take a tablet of prochlorperazine here when there's a recurrence. But let me tell you, early naproxen sodium or this combination, naproxen and somatriptan, are the best combination for prolonged attacks, which are very distressing for the patient. What about headache persistence? That means you give a medication, but there's no response at all. Now, this is a situation where the same same dose of triptan should not be repeated because this triptan has not worked in this patient, does not work at all. And therefore, there's no point giving another dose. It won't help. Of course, we have to see that patient has taken treatment early, patient has taken the right dose, has taken an antiemetic, and the right formulation here. If it's an early morning attack, he has to go for a nasal spray. And then only we can say that this headache persistence is really a persistence or a mistake of taking the medication. Now, how do I manage a patient who do not respond to headache persistence, or who gets or this scenario where there is no relief, there is recurrence of headache? This is my protocol. I try always prochlorpromazine 5 milligram out dissolving 5 milligram. We can go to 10 milligram also. It's very safe, and it has a good analgesic effect and works even after hours of migraine. So this should be tried. And if this does not work, then we can go for a ketorolac injection. I normally give 5 milligram if the response is not. This is also very effective rescue medication. Sometimes I use Decadron 8 milligrams intramuscularly with pantoprazole tablet. This drug is very effective to prevent the headache occurring next day. It may not work immediately, but it may work next day. So this is also a very good molecule we can try. And of course, the patient does not respond to headache, it's going on and on. We normally advocate hospitalization, where our main line of treatment is good hydration and probably a dose of clonazepam to relieve their anxiety. A rescue medication is very important to write to our patient because it will reduce their suffering, disability, unnecessary phone calls to you. And of course, they may not have to visit an emergency hospital because they can get this injection in a nearby clinic. So this is about rescue medication. How headache diary helps, patient can recognize triggers and then is ready to take the medication. He can avoid triggers or take a medication. Headache diary, we write all the primary symptoms in their local language. Patient can read those symptoms and recognize that this was an attack of migraine in the beginning, and then they can treat early. We also, in the headache diary, tell our patient to note the timing of headache. Was it early morning? Then they may have to go for nasal sprays. We also teach our patient why their treatment failed. Were they late in taking the medication? Were they using a wrong formulation, oral instead of nasal, or the dose was not adequate? We teach our patients to begin with half dose and then to double the dose. And whether they had any adverse effects of medication. So headache diary, maintaining a headache diary is a very helpful way of managing migraine attacks. Now, why the acute treatment fails? It may be failure to take the treatment early. It may be that patient has not taken anti-emetic drug like domperidone 10 milligrams. We always advise our patient, if possible, they should withdraw from sunlight, noise, and take rest. Was a dose inadequate, which is possible? Incorrect formulations, very important. Nasal formulation, if not given for early migraine, morning migraine attacks, the oral tablets may not work. Failure patient taking the same triptan again, no. Triptans, if not effective, after 2 trials, should be discarded. Sometimes patient has been taking a lot of analgesics prior to coming to me, and therefore, in the initial 1 month, they may not respond to the abortive treatment of migraine. And sometimes it could be an unusual migraine called as a status migraine, which may need a different type of treatment. So what is migraine toolbox? As I told, a patient of migraine may have a combination of attacks, She may have a regular attack of migraine where naproxen sodium would work. She may also have early migraine attack where nasal sprays would work. And she may get in a month another attack which is very long duration, where probably naproxen sodium and sumatriptan combination would work. So we write prescription, we decide, we detect the type of migraine attacks they are having, and we write them the corresponding prescription like this so that they have the complete arms with them to handle different types of attacks. This is known as the migraine toolbox, and it is a very effective way of managing migraine at home. So if I conclude, dear colleagues, what are the messages for management of an acute attack of migraine? One should be the migraine attacks pain. We should know that not only it's pain, migraine is a migraine plus disorder. It's not only pain, there's distressing symptoms of nausea, vomiting, sometimes phonophobia. Remember that domperidone and naproxen is my first line medication, is one of the most effective medication if given early in the attack. This is 10 milligrams, this is 250 milligram, very effective. You must try to classify, stratify the attacks, not only the severity. By the time patient comes to me, they're usually moderate to severe, but also the timing of the attack when they get, which time in the morning or in the evening, lot of nausea or not there, how long they last, and time to peak. And depending on this classification, we have to design their treatment. Remember, one patient may have 2-3 types of attacks, and so you have to give them a toolbox to, like we give different sizes of screwdrivers, we have the toolbox so that each can fit in a particular type of attack. The key is that we have to match the treatment and the attack, otherwise patient may not respond. And remember, prochlorpromazine is a very good rescue medication, 5 milligram tablet. Otherwise, ketorolac is also a good drug if the patient continues in headache without responding. Last but no less important is that in understanding early detection of migraine, recognizing the prodrome, taking the treatment, patient has to understand this. And we have to teach our patient how to recognize early migraine symptoms, how to recognize the prodrome, how they can match the attack and the medication. They should understand this. Not only that, we should also explain the right dose. Indian patients are very much afraid of increasing the dose, and they quite often underdose. And we have to tell them, even 10 milligrams of Triptan is safe. It will not harm them. But an attack of migraine and repeated attack of migraine would lead to chronic migraine, which would be more difficult to treat. Similarly, we teach them that how early treatment is so effective that you will have quick response, you would need less dose, and you will prevent chronification. So early treatment is very important for patient to understand, rather than they delay their treatment, thinking that the headache may subside of its own. We also explain them when to repeat the medication and when not to repeat. If they are delaying treatment, then there's no point repeating the same medication. Next, they should learn, next time they should take early. So few attacks of migraine teach the patient and the clinician how to manage the subsequent attacks, and therefore it's important that we remain in touch with our patient, maybe through our clinical assistant because of the increasing load in our day-to-day OPD. But if you are not in touch with your patient through some means or the other, more so in this era, then you will not be able to manage your patients properly, because one drug may not help the patient and you may have to revise the treatment after at least observing 2 to 3 attacks of migraine. I think I would stop here, take some questions, and I hand over to Dr. Manjusha to start the discussion. If there are any questions, we can take.
First question from Dr. Tapan Biswas from Kolkata.
Yeah.
How is migraine in geriatric patients to be managed?
Yeah, that's a good question, because all the time I have been talking about migraine in young patients, So geriatric is really old patients, and to have migraine at that age is very unusual. So when we get a patient who is above 65, elderly with headache, our first diagnosis is temporal arteritis. Our second diagnosis is probably TM joint disorders. And our third diagnosis is the obstructive sleep apnea. Hypnic headaches are also common in elderly, but we would be very reluctant to diagnose migraine in elderly. But if patient has migraine history and we think it's migraine, then probably NSAIDs may be the first choice of abortive treatment for migraine. Yes.
Dr. Pradeep from Bangalore asks, how do we differentiate migraine from tension type of headache?
Yeah, migraine is a disabling headache, whereas a tension type headache is not disabling. So if a patient is not able to work during a headache episode, it's usually migraine. Migraine is associated with nausea, vomiting, phonophobia, photophobia. Tension type headache is usually none. Some nausea can be there. And there are triggers for migraine. So taking the whole picture, we can distinguish tension type headache from migraine. As I told, prodrome is a feature of migraine. Neck pain, neck heaviness, irritability, yawning, pain around menses, they're all migraine episodes, then tension type headaches. Yes.
Dr. Ishwar Prasad from Bangalore is presenting his type of headache and asking your opinion. He says he has headache since college days, which used to subside with paracetamol and propranolol 10 milligrams. Now he is on antihypertensive drugs, telmisartan and amlodipine. He still gets headache every afternoon, and even if he sleeps for 5 minutes, the headache fully subsides without any medication.
Yeah.
What kind of migraine is this?
Yeah, it's very important that it may not be migraine, because if there's no nausea, vomiting, phonophobia, photophobia, then it may be just a tension. It looks more like a tension type headache which responds to sleep. If it is migraine, then he should be better. He should be switched over to metoprolol, beta blockers, which would manage both migraine and hypertension. Yes.
Dr. Ganesh from Jalna, what is the role of vitamin B12 in migraine? Is there any correlation between vitamin B12 deficiency and migraine?
Yeah, there's emerging evidence of vitamin B12 deficiency and migraine. And the next talk, somewhere 2 weeks from now, we are talking about prophylactic treatment of migraine. There is a role, there's emerging role of B12 deficiency. Yes.
Dr. Chandan Kumar from Agra, what is your drug of choice for a pregnant female with migraine, prophylactic and abortive?
Yeah, good question. We will discuss sometime later. But prophylactic treatment of migraine, my drug of choice would there's only one drug we are left with which is most safe, that is probably beta blockers. But one interesting thing is that migraine becomes less in pregnancy. If it's there, then we have to give beta blockers for initial 1 month or so. But again, non-pharmacological treatment maybe should be the first choice of treatment for migraine patients. For acute attacks of migraine, I would begin with paracetamol only. I would give crocin paracetamol only. Yes.
That was the last question. I hand over to Mr. Deepak Naik for a vote of thanks.
Sure, sure.
So thank you very much, doctors, for joining in for this interesting webinar on headache. Dr. Ajit Verma sir nicely illustrated the acute management of headache, and tune in for another part of this webinar, which will talk about prophylactic management of headache. So thank you, sir, for your time and your beautiful presentation on acute attack and how to take care of that attack in the treatment of migraine. Thank you, Dr. Manjusha, for coordinating this session with question and answers. And thank you, doctors, for tuning in and taking out your valuable time to join this webinar. Thank you also for taking care of Indians during this COVID-19 crisis. Stay safe, stay healthy. Please continue support to Health and You products. This is Deepak Naik on behalf of Health and You signing off. Health and You is always together. Thank you so much, sir.
Thank you.
For your cooperation.
Thank you.